Olá, colegas. Vamos a empezar em minuto.
Colleagues, we will be starting in just a second. We are allowing time enough for other people to connect.
Muy bien.
Okay.
Já temos aí mais de 110.
I see that we have more than 110 people in the room already, so people are connecting.
Podemos empezar. Queria
So with that,
a todas,
greetings. Greetings to everyone.
pela participação
Thank you for taking part in yet another webinar of RedETSA. Today we have a very interesting program. And
registrar
first,
marco muito importante, momento
I wanted to say that this is a very important moment.
número 40.
This is our 40th webinar. So that is something that's very significant, very symbolic,
Sem dúvida para celebrar.
and it's definitely reason for celebration. For many years now, we have been working through our network to disseminate important information, have discussions within the network. So reaching number 40 is an accomplishment.
Sem dúvida há, pero não recordo de outros programas webinários que
I can't think of any other webinar that has reached
é algo muito
their 40th edition. So it's something that definitely is to be celebrated. So today is a celebration day. Today, we're going to be talking about something that is of great interest. In the most recent meeting held in Jamaica, we came up with the idea of this webinar. We talked to some colleagues at that meeting, and the whole idea of EQ5D as a tool for measuring quality of life related to health and supporting decision-making by discussing experiences of its use in the Americas region. So before we greet our panelists, our guests, I wanted to make some housekeeping announcements having to do with the webinar. First, we have interpretation. We have simultaneous interpretation on 2 channels, in addition to being able to listen to the floor. So we have an English and a Spanish channel, and you can listen to the interpretation by going to the bottom of your screen and clicking on the interpretation icon.
interpretation. So if you are English speaking and you haven't found how to choose the translation, if someone is speaking Spanish, you want to listen to interpretation, you can choose in the menu below interpretation, then you can choose the correct channel. Bien. Y también, si alguien le prefiere,
Another thing, if anyone doesn't need interpretation, if they understand both languages, you can just leave the original channel on. Also, I wanted to say that, and this is something we've always done in all of our webinars, but on the RedETSA webpage and on the PAHO YouTube channel, we will be sharing this information. Also, we're going to have a Q&A time, and for that, you can go to the Q&A. That too is on the bottom of your screen. So please use the Q&A to send us your questions. If someone sends us something through the chat, we will try to look at that too, but we would appreciate you putting your questions into the Q&A. And that way, at the end of all of the presentations, we will be able to have a Q&A round. I wanted to thank Malin Holman for having organized this webinar. She does impeccable work. Also, I want to thank our technology assessment team. We have people, we see Ribeiro, Caroline, and our technology evaluation team, the HTA team. And I assume that you know me, but I didn't introduce myself. My name is Alessandra Limgruber, and I am the regional advisor of PAHO for Health Technology Assessment and Access, HTA. And in recent months, I was given the role of unit chief. This is an AI appointment. So I'm also looking at access to health technology and products, medication and inputs. So I am speaking on behalf of our director, Dr. Judith Rios, and she is going to try to connect, but we don't know if that will be possible. So she asked me to please open this event on her behalf. So with that, I merely want to welcome you and express our appreciation to our panelists. Our panelists who are here with us. First of all, Henry Bailey from the University of West Indies in Trinidad and Tobago. He was with us in the EDSA meeting and made a major contribution. Also, I wanted to welcome and thank Federico Agustovic, who has been a friend for a very long time. He works at the Collaborating Center in the Health Technology Assessment, and he works at IECS in Argentina. Also, I would like to thank Graciela Fernandez from the National Resource Fund in Uruguay. I'm glad she was able to join us. And she, too, has been with us right from the time when RedETSA was founded back in 2011. And also, I wanted to express our appreciation to Victor Flores Procel for being with us. He is from the Public Health Ministry in Ecuador, and he too is a member of our network. As you know, our topic for today is we're going to be talking about the Euroqual questionnaire and the EQ5D, which has been used worldwide to assess variation in quality of life that is health-related for different populations, for different pathologies, all of this to support decision-making in terms of health coverage. Now, the idea behind the webinar that we're now beginning, the idea is to share conceptual aspects having to do with the estimation of these preferences in different countries of the region, how the questionnaire can be used to assess variation as well as quality of life health-related, and to also estimate the disease burden. Also, we would like to share some experiences from the region and look at examples of the way that this tool is being used in the region. In this way, and with no further ado, I don't want to take up too much of our time, but I did want to say that I am really happy that we are holding the 40th webinar, and that following up on a very successful meeting in Jamaica. Hopefully, our colleagues from Jamaica are here with us. I can't see the whole list of participants right now, but we do have more than 150 participants connected at this moment. I hope that the colleagues from Jamaica are in our audience, but I did want to say that the meeting there was very successful. And this year, as you know, we're going to hold an event in the Dominican Republic. And there we have Marin, other colleagues from the Dominican Republic, and that will be in November. Hopefully everyone will attend, and we're beginning to make the preparations for that meeting. and I am certain that it will be a very successful meeting and an important milestone in RedETSA's life. So once again, I want to express our appreciation for those who organized this webinar. I know that a lot of work went into organizing the meeting. And at the end of the meeting, I'm going to ask Vanya to give us some closing remarks. I probably will not be able to stay until the end. So Vanya will provide the closing, and I am sure that she will talk about the next webinar. Also, she is helping us a lot with organizing HTA. So it's a lot of work, and we have to express our appreciation for the work done by the Secretariat. And with that, I call on Malin. Malin will be moderating the session. I hope that you have a wonderful webinar. Thank you very much, and we will be in touch. Thank you, Alexandre. First of all, good morning, everyone. My name is Malin Holman, and I belong to RedETSA's Secretariat. Today's first presentation will be given by Henry Bailey. Henry is an economist, and he is Vice Dean of the University of West Indies in Trinidad and Tobago. He worked in the pharmaceutical industry, worked with medical devices for more than 20 years before going back to academia. So the floor is yours, Henry.
Well, thank you, Malin and Alexandre, and the PAHO team. Thank you for this opportunity, and also for the opportunity to present in Jamaica. That was pretty awesome. So without further ado, I'm going to share my screen. Sorry, I'm just trying to move stuff around here to get my presentation. I'm sorry, guys, we're just having a minor glitch here. Okay, so I'm gonna be discussing. Pardon me, I'm just trying to move something out of my screen. It's not helping. I'm going to be discussing EQ5D in the Caribbean region, our experience with EQ5D from the perspective of HTA. Pardon me for this, but I keep having something happening on my screen that is. Okay, I've got it now. Okay, I'm good now. Okay, good. Yeah, from the perspective of moving our health system towards HTA, and I live in the Caribbean, a very small islands, very small countries, and we have had some interest from the university in moving or helping health systems towards HTA, and there have been some challenges. We of course have problems with capacity, with data, with working with technocrats, with ministry. The idea of something like HTA to the average Ministry of Health in our systems is a huge jump because we have nothing like it. It's completely different to the way that we evaluate or think about healthcare and health technology. It dawned on us a few years ago that we can actually use health outcomes projects as a segue into HTA. The reason is that this and you'll see how we've done this in Trinidad and how we're approaching other islands, other countries, is that we could start with simple projects that people can understand easily, and as we build capacity in working with health outcomes, we're also building capacity in the health system of using health outcomes, and eventually we could get to a point where we can perform economic evaluation and so on, and have an audience, have a set of people who can not only do this, but who could work with it and understand it. This is based largely on what we presented in Jamaica last year, but with some updates and with some more focus on this issue now, moving towards HTA. So just a quick snapshot of the geography. This is where I am. This is Trinidad and Tobago here. We've done work with EQ5D in Barbados, Jamaica, Belize. We've done a population norm study in Colombia, and we have done a Caribbean-wide study that would be relevant to these other islands. In fact, we're doing some now based on we'll see now. Basically, there are two classes of health outcomes measures. There are disease-specific tools that are designed specifically for an illness that capture dimensions or things that are important to patients of a specific disease. And then we have generic instruments that are not specific to a disease, but that we can use in any illness. And these are used. One use of generic instruments is to give us a quality adjusted life year, a quality adjustment value. So very, very quickly, because I don't have much time, but EQ5D is a health state classification system that allows us to take any patient of any illness or any person, any respondent in a survey into a coded health state. And we have a value that we can assign to each health state, called an EQ5D index value. And I'll just show you briefly where that comes from. So once we have a collection of all health states in the EQ5D system, and we can assign values or quality adjustment values to each state in that system for a country, we have a very valuable tool that allows us to do all sorts of burden of disease, as Alexandra mentioned, burden of disease, inequality studies, economic evaluation, and so on and so forth. So this, for somebody who has never seen EQ5D before, this is what basically it is about. There are 5 dimensions that are in this order: mobility, one's ability to bathe and dress themselves, one's ability to work, go to school, enjoy leisure activities, and so on, and the amount of pain and the amount of anxiety or depression that the person is experiencing. In the original EQ5D instrument, Eurocall instrument, there were 3 levels on each of these dimensions: no problems, moderate problems, and extreme problems. And so with this matrix, we could take, with 3 levels and 5 dimensions, we could take any person and ask them to report, well, how which of these 3 best describes your situation today. And we do that for each dimension. And for a person, we might get this. We might get somebody who has no problems walking, no problems bathing and dressing, some problems going to work, extreme pain, and moderate anxiety. And the next person in our survey may have a completely different health state. The thing is, this is a unique health state for this person, and we code the health state using the dimensions in this order. So this state here would be coded 1, 1, 2, 3, 2. And that number, for somebody who works with EQ5D, that code tells us a lot about that person. And it's just one thing I should say now is that this abstracts completely from a disease. This could be a patient with cancer. It could be a patient with the flu. It could be a patient with a broken arm. It could be any number. But this just focuses on the health outcomes. Okay. In this 3-level system, there are 243 possible combinations. And so to use index values, we need a value for each one of these combinations. And the process of doing that is an extremely technical one. I'm not going into that now. And the purpose of this slide is not to explain how to do it, but it is a very technical thing that we do in the Eurocall group for a country. This is the original EQ5D value set for Trinidad and Tobago, and you can see for each state, like we have 11232 here. 11232 is somewhere down at the bottom, and we have a value, and these values would be, because we did this with a representative sample of the population, these values would be the quality adjustment values for the population of Trinidad and Tobago. This is a Trinidad and Tobago value set. Okay, we did a series of studies. We showed the importance of using national value sets for a specific country. It's pretty important to use a value set for specifically developed within a country. Where we don't have this, we can use one from somewhere else, from a culturally similar country, until people can create their own value set. Okay. So for Trinidad, we did a set of pilot studies and eventually did the final study, which we published in 2015. And now Eurocall has now a 5-level instrument. They've gone from 3 levels to 5 levels. It's much more sensitive. And we have just completed the 5-level study for Trinidad and Tobago. And we've also just completed a study for Bermuda, a 3-level valuation study for Bermuda. So that's it. What EQ5D gives you is a set of index values that you can use as quality adjustment values. It gives us a set of values of self-reported health, the way the patient or the respondent expresses how they feel, how good they think their health is. And it gives us a health state for each person. I'm going to switch now to some of the applications that we've done in our region, and then I'll speak a little bit about how we're using this to move the system forward. So in terms of applications, perhaps the most basic or the most straightforward application is something called a set of population norms. And what this is that it gives us a baseline for a country. So if you look at a group of people, a large group of people, not everybody is going to be in perfect health. There are going to be some people on any given day who have a flu, who have some minor ailment, and sadly, there are going to be other people with more permanent decrements in health. So it's pretty useful to measure population health and get a sense of what baseline values are, especially in HTA, where we're gonna need a baseline for the population. We can't assume that every treatment is going to return every patient back to the health of Superman or some perfectly healthy individual. And so we've done this kind of work up and down the Caribbean, where we take the health, the index values, this is the VAS, is that measure where the patient just tells us on a scale of 0 to 100 how well they feel. And so we have this by demographics, by you name it, income group, age group, gender, ethnicity, et cetera, and we can use these to track how health deteriorates as the population gets older. So this is index values by age group for 4 countries in our region. And we can do this for people with a specific illness. We could do this for people who live in a specific region. We could do, any number of possible ways of looking at this. This is a schedule or a matrix of age and gender on the 5 dimensions and the 5 levels. So this is a pretty useful tool as well for clinicians who want to compare a group of patients with the population. We have information on what percentage of the general population, let's take, for instance, pain and discomfort, what percentage of the people in the 55 to 64 age group reported no pain, slight pain, moderate pain, etc., etc. And you could compare a patient group or a demographic group to the population, or compared to demographic groups, as we are doing with this in some countries now. So we've done these population norms studies in Trinidad, in Belize, in Barbados, Jamaica. We also set up a Caribbean population norms study. We've done this for Colombia, and we're doing this now for Bermuda as we speak. Our colleague Ricky Brathwaite is spearheading the data collection for that right now. We've done a lot of work with diseases, primarily quality of life studies. So we've done some work with ophthalmology. This was the first major study that we did in the Caribbean with EQ5D. And we looked at the impact on quality adjustment value of some interesting demographic variables. So for instance, literacy has a huge decrement on the health of people in Trinidad, in my country. Being illiterate really puts a patient kind of in the same range of health decrement as somebody who has had a stroke. So there's something to be said. This might have policy implications if we think that through. Here is a comparison of hemodialysis patients with the population, using the age groups and the 5 dimensions: mobility, self-care. And this would allow a policymaker or a clinician to get a view of the experience of hemodialysis patients that they otherwise might not have. Here is a vast. This is just the measure where the patient tells us their health rating on a score of from 0 to 100 between PD, peritoneal dialysis, and hemodialysis. Done a lot of work on this in Trinidad because peritoneal dialysis had a bad reputation when it first came out. So we wanted to understand in Trinidad that. Wanted to understand that, and so we've done some studies on this. We can take a disease-specific instrument, like this is a kidney disease instrument that has in it dimensions or items that are important to kidney patients, and we can use regression models to figure out the impact on overall health of those symptoms. So this is a study that we published a couple of years ago where we took this is just a summary of the physical component score from a kidney instrument. And we see here that the coefficient is like 1.5% of the full quality scale is removed from a kidney patient just by the items in the PCS. So in other words, what we're doing is we're seeing what different manifestations, what effect different manifestations or symptoms of an illness have on the measured overall health. This is a multi illness study. We looked at cancer, kidney, diabetic, and heart patients and compared them in the using the EQ5D measures. And we've had some other findings that don't have the time anymore to go into, but we found some really interesting things about the living circumstances and the domestic arrangements of these patients, where we could make huge gains in the health and the lives of people, perhaps by looking at how they live rather than the treatments that they get. Again, it's insights that we would not otherwise get. This is our most recent disease work is on multiple sclerosis in Trinidad and Tobago. And again, we did the full gamut of EQ5D measures, the states, the index values, the VAS values over time and within age groups. And we found again some really striking things. And I wouldn't go into details, but the idea is that these people in Trinidad are in a very, very good place. They have a very, very high mental and emotional health. This has not been observed anywhere else, and we're investigating now to understand why that is so, and to see if we can use that understanding to help patients with other illnesses. Also, this is the first study where we've taken an academic document, an academic study, and moved it towards a policy impact. So we've just written, this is March 2024, this is now, we've just completed a policy impact statement based on this health economic analysis of MS patients. We've written a newspaper article, and we're taking this now and meeting with policymakers is basically the study written in plain English that people who are non-technical can read and understand, and we believe this would actually a large part of this came from a workshop that we had in Jamaica at Tahoe. So again, I thank Alexandre, Vanya, and Marlon for that opportunity to go to that workshop. That was really awesome. This is essential if we're going to use health outcomes, if we're going to use EQ5D to inform policy and inform decision making. So we'll see how that goes. We did some work with COVID. We had a cohort of people, and we got their health status before and after the lockdown. And again, this is just a comparator, a study that compares health outcomes using EQ5D before and during the COVID lockdown. We're using this for inequality studies. We've done we have one paper that looks at several countries, including Colombia, actually, where we're using EQ5D. We had some data from 2012. Demographic, age, ethnicity, rural versus urban, and for 2022, 23. So we have now a 10-year gap, and we can see how health inequality has changed. So for other people who are interested in this, you could take this and do, if you're in any of these countries, you could take this and do this there as well. If you just do a national EQ5D study, very simple, get people to just say where they are on each of those 5 dimensions. You can test how inequality has changed in your country over the last 10 years using this measure. Okay. And we also are doing economic evaluation. So the first economic evaluation we did, this is a cost per QALY analysis of course, PD, peritoneal dialysis versus hemodialysis for Trinidad and Tobago. I would not go into the details, but for those of you who work with cost utility analysis, you could see that when we include lost output, the ISA, the whole cloud moves, or most of the cloud moves into the 4th quadrant, which is really encouraging. Again, we need to take this now and put it in a makers to encourage. We've done some work beyond health. My interest also is in economic development, and we've looked at how the health of a self-employed person affects the way that they see their business environment. And I hooked up with these guys because this is something that they were interested in before. So I just took EQ5D, I went to them, and we had a discussion. And it's amazing how this resonates with the idea, with the models that they had before they had this actual numerical measure of health outcomes. Okay. So we have a bunch of ongoing work. One of the things I'm writing now with my colleagues, with Frederico, who is with us today, Marissa, Lucila, and Victor. I think Victor is here as well. Is there a scoping review of what has been done with EQ5D in Latin America over the last 5 years? This should be out in a couple of months' time. I'm very interested in doing these valuation studies in Central America and the Caribbean. Again, I asked this in Jamaica. If there's anybody who is interested in this, please reach out to me. We have now a really exciting development that we did not have in November. We have now new possibility for doing these studies that cuts the cost tremendously. It's called a discrete choice experiment with duration. And this is about to be recognized and accepted by the Eurocall group as a valid means of doing a valuation study. So this is really awesome. So please email me if you're interested in developing a value set for your country. I'm already in discussion with a couple of people who are probably online. But if we've not had this conversation before, please reach out to me and we could discuss that possibility. And that's it. I have a paper here that I wrote with you. I think Manuel Espinosa might be in this meeting. I'm not sure. But with these colleagues that explains basically how we're using health outcomes, how we're using EQ5D to incrementally move the health system towards using economic evaluation and hopefully move the system eventually towards HTA. So thank you for the opportunity. I believe I might have gone a couple of minutes over my time, and I'm sorry, but it was really great to have this opportunity, and I'd like to thank once again Marlon and your great team to be here today. Thank you.
Thank you very much, Henry, for your presentation. It's very interesting, all the work you are doing in the Caribbean region. So now our next presentations are going to be in Spanish. So, les recordamos que hay interpretación.
We'd like to remind you that there is interpretation, and in the lower portion of the Zoom platform, you can select whether you want to listen to the main audio, English or Spanish. We're now going to hear from Federico Austochi. He's a physician and Master of Science in Epidemiology. He's currently Director of the Department of Health Technology Assessment and Health Economy at the IEX, Assistant Professor of Public Health at the School of Medicine of the University of Buenos Aires and Senior Researcher at CONICET Argentina. Federico, you have the floor. Thank you, Malin. It's a pleasure really to be here to celebrate RedETSA's 40th webinar. We have been participating since the beginning, and it's very interesting to see how many people are following us and are interested in these topics. So in the next 15 minutes, I hope to move forward a little bit. You just heard from Henry. The EQ5D is a generic instrument applicable to any person in a population, whether healthy or with a health condition, and is therefore an instrument that has a page and then the visual analog scale, the VAS. So it's a very easy instrument, easy to complete, and actually it's already incorporated in some health surveys in different countries. So it is truly an instrument that's been used since the late 80s. This is my disclaimer, because I am a member of the Euroqual. It's a foundation or a non-profit organization that promotes the use of tools for quality of life having to do with health and decision-making since the late 80s. So in these next few minutes, I have been asked to talk about some of the basic concepts that might help fully understand the role of EQ5D. and the part it can play in decision making, and show or share some examples of work that has been carried out in the past 20 years and conclusions. And lastly, if we have enough time, we might be able to have some discussion or Q&A. Now, looking at the concept, one can talk about one concept, which would be quality of life of people, population, and quality of life is a much broader concept than health or quality of life having to do with health, because it incorporates safety, education, housing, all those aspects that those of us who work in the health sector, we obviously can't improve all the quality of life or evaluate it all. We just want to make sure that their health improves. So we have this concept, which is health-related quality of life, which is the aspect of the quality of life that could be linked or related to different pathologies or health issues, and that incorporates physical, emotional, social elements, as all of these can be affected by treatment or preventive measures. So this is the focus or the purpose of the health system. We want to improve health or quality of life related to health. Now, the problem is, well, in geometry, and when they agreed that the meter was going to be the master measure for the world, and it is used throughout the world. So to measure health, there is no standard meter. Health has many aspects. Some are objective, others are subjective. So as there isn't a standard meter, we need to agree and say, well, what would we like to measure? What would we like to evaluate in order to see if the health system works, if the treatments work, if people improve, if there is inequality, as Henry showed in some studies. So for this reason, some decades ago, the qualis were proposed, and there are many instruments, and you're going to hear them as PROs, the patient-reported outcomes. These are instruments that are used like the SF36, EQ5D, and many others. Now, the cardiac functional use that many of you must be familiar with. This is a descriptive classification. EQ5D, as Henry showed, does have a descriptive element also. What is the health state of each person in that descriptive classification? Now, if we want to use it, or if we want to use these instruments for decision making, whether it be to allocate resources or decisions having to using the cost effectiveness or cost utility studies, then we're not interested only in the descriptive, because what we need to do is assess what is called assess the preferences given the different health states, or the utility, as is often referred to in economics. So the cost utility studies are those that try to assess cost based on the qualis. So there are many instruments to measure the quality of life related to health, but not that many that assess preferences or values. So what is this value scale? Well, it has to be by consensus, just like the standard meter that in those days was reached by consensus and was quite successful throughout the year. So how can we measure the days or years that the people live? Well, through a valoration scale that arbitrarily has one assignment. If I have 1 year in perfect health, my quality will be equal to 1. And then there is another anchor, which is death. To be dead has 0 when you come to utility or qual So QALYs can range from perfect health 1 through death 0, but also there are what are called health states that are worse than death, worse than being dead. I'm sure that many of you, if you're quadriplegic or if you have a health state that doesn't allow you to communicate or to do anything in your lives, you would prefer to be dead. It's not nice to talk about these matters, but you would prefer to be dead rather than in such a very terrible health state. So there are some health states that are very problematic, very severe, where there can even be a negative quality, a negative utility. So this is the space in which the quality of where the HR quals move. One is perfect health, and a negative one when we look at Munch's painting. So if we can bring this down to measuring the quality of life from those anchors, 0 to 1 or worse than death, if we have data about patients who are undergoing treatment and compare them to others receiving a different one, and this has to do with survival also, because that's also important in quality of life, and then we'll be able to compare the healthy, the quality, the QALYs, or the comparison between the PD or the HD to be able to assess and to value how the people feel about each of these two different treatments. Now, let us go to the meters, we would say in Argentina. And let me tell you about some experiences of possible uses of the EQ5D tool. In our group, we have over 40 scientific publications since we began using this research angle. I selected a few of these studies in order to describe some of the things that can be done with EQ5D. On the one hand, we have the populational preference valuation studies, and Henry showed some of these done in the Caribbean. The advantage of these studies is that if they exist, one can measure the national or local or contextual QALYs. Now, if they don't exist, then one can use valorization for neighboring countries or countries that one believes are culturally similar to one's own. So this is a basic building block when trying to move forward with the EQ5D agenda in economic valuations and in determining different agendas. We conducted a number of studies in our region about 20 years ago, and this was with a 3L. Henry was telling us that the first instrument had 3 levels, and in the last 10 years, we have now had one measuring. The first measures the 5 dimensions, but now with 5 levels into each of them. So this instrument is a little bit more sensitive. Our team was the first one to do the first study of social preferences in our region. We did it with Uruguay, and Brazil will be talking about this because they went into greater detail. And with the National Institute of Health and the Ministry of Peru, we conducted a preference valuation study in that country. So that is one of the areas and one of the documents we've been working on, one of the papers. Some countries in the region don't yet have their own data, so they can use those of a neighbor, for instance, a neighboring country, or attempt to conduct their own national study, because it is not really that complex to do. Another use is for economic assessments. These can be based on decision models and also economic assessments with individual patients. This is an example of a pragmatic clinical study in 18 health centers in Argentina, comparing of primary care and text messaging that was personalized for high blood pressure patients over about 1,400 patients. They were followed over an 18-month period in order to assess the effect. The basic outcome was millimeters of mercury, but also the HR qual was also used using the EQ5D. So here we see the health outcomes table. So you can see that patients began with a utility qual of 0.819 in the intervention group, and after 18 months it increased to 0.90. In the control group, we can see the same values. What we end up measuring is the difference between the differences. That's what is done in clinical trials, after all. What has been the gain in qual, and then adjusted on the basis of different variables that were imbalanced. The bottom line, the conclusion, was that the intervention gained 0.05 or 0.04 qualis more than the control group. So those who know about economic assessments, one needs the difference in effectiveness and the difference in utility, but we also need the difference in cost. So that way we could calculate the ICER, which was $3,300 for quality, because the intervention did provide an improvement. And the threshold in Argentina at that time was about $10,000. Today, we're much more poor. So this was a highly cost-effective, therefore very efficient intervention, and was well worth adopting. Other uses for EQ5D is populational studies, whether they be national, regional, general population, as some of the things that Henry showed us. One example, for instance, is the National Survey in Argentina of Risk Analysis. This is done about every 5 years, and EQ5D is used for this survey. This is an example of an Argentine HR qual. It is one of the areas of survey. We can see the distribution of people when it came to limitations in the different dimensions of EQ5D3L, which is what we had at the time, and what was the Q of the quali, or the EVA, which is the visual analog scale, based on the responses received through self-reported health. And one can also assess regional differences, provincial differences, using the trade-off method, the TTO, or the self-reported, or even the social preferences. And to finalize, I want to tell you about a new child that is being born gradually from the Euroqual group. It was also using the British health system. They'd like to try and come up with a measure that is a little bit broader, doesn't only look at the health-related quality of life, doesn't only look at the patient aspects, but also take in aspects having to do with caregivers. It has to be something a little bit broader and not strictly focused on health. So what is being designed, it's still in being worked on. It is not something that Euroqual is recommending for countries to use as yet, but it's called EQHWB, which is health and well-being, Euroqual health and well-being as an instrument. And you see that there is a longer, more descriptive measure to better describe the health state and the health-related quality of living life of people. And it has a shorter version with 9. It has the 5 dimensions of EQ5D, but it adds a few other relevant aspects, such as fatigue, cognitive aspects if one has any issues, also loneliness, or to be able to control one's life, feel that life is under control, in other words. The short version is the one that is being assessed right now, and the proposal is to have some measurements of utility in order to use the short instrument as an instrument with a broader focus than EQ5D, so that it's not only the health-related quality of life, but includes some other aspects that go beyond health. Okay, I'm hope to have complied with the time constraints, and I will be happy to answer any questions you may have for me afterwards.
Muchas gracias, Federico. Excelente tu presentación.
Thank you, Federico. That was a wonderful presentation. Before I introduce the next speakers, I want to remind you that you can send us your questions through the Q&A. Now we're going to give the floor to our colleague in Uruguay, Dr. Fernandez. Graciela Fernandez is an intensive care specialist, and she's a specialist in health care management. And at the present time, she is the technical and medical vice director of evaluation and management in FNR. Please go ahead. Good morning, everyone. It's a pleasure to join you for this webinar. I wanted to thank the organizers. Thank you for this opportunity to share our experience in this area. This is part of the National Resource Fund, FNR. And of course, I congratulate you on this 40th webinar. This is a very useful mechanism to share these concepts across the region. Now, I am going to share my screen so that you can see my presentation. I hope that you can see my screen. Okay. I hope that you can all see my presentation. Yes, we can. Thank you. Thank you for confirming. I wanted to tell you a bit about the experience we did with some work that we did some years ago in Uruguay. Federico just touched on it, and that was evaluation of the social assessment using EQ5D in Uruguay. Very quickly, because these concepts have already been covered, in terms of the preference or the assessment of a person regarding his or her own health, this has a lot to do with cultural, social, religious, historical influences. And often the assessments of the same health status may vary significantly according to some elements like those I just mentioned. Even within the same country, there can be variances because of aspects like those that have already been mentioned. I'm sure there are others too, and all of that affects self-reporting on health status. And that is why it is so important to look at the multiple effects. We have to look at the perception of health on the part of the population in a country or in a region. And also this ties in with economic studies. And as already been said, we can also monitor a population following an intervention. It is very important then to know what the health status and its self-assessment is in a given population. We talked about cost utility analysis using QALY as a measurement. And also, this allows us to look at the perceived quality of life and a given health status related to years gained or lost. So that is the way that we reach the quality. I'm having problems here with my computer. Here we go. Okay, the objective of the study we did in Uruguay in the National Resource Fund, this was some years ago, was identifying the value assigned by the population of Uruguay to the 5 statuses of health and combine that with the 5 dimensions of health that were considered by Euroqual. That is something that Henry already covered. So it was the first study of social assessment in Latin America to be done on a country scale. Now, we did hear about a regional study in Argentina that was covered by Federico, and here we covered the whole population of Uruguay. There, we looked at the EQ5D, and this was a collaborative study. Federico was involved in this study, and also Euroqual and the National Resource Fund cooperated in the study. It was a cross-cutting study, and it took as a sample that represented the population pyramid in the country. It was a survey that was done face-to-face by trained survey takers using EQ5 deemed, and the initial objective was to include 1,000 subjects over the age of 21 and below the age of 75. Now, I wanted to tell you a bit about the dynamic behind this effort. I wanted to tell you of some of the problems we had. It's not that I'm trying to be negative, but I think it is important for you to be acquainted with the problems that may arise. And in this way, you can foresee problems that you may find along the way. So, as I said, we had a survey taker that is well known nationally, and this person always uses computers to do these surveys. They survey things having to do with business, with political matters, but in doing the EQ5D survey, that was something completely beyond this company or this person's area of expertise. So it was important to train the survey takers so that they would know how they had to ask the question, the time they had to give people, the explanations that were needed so that the respondent would understand the situation. And here in Uruguay, usually survey takers charge by time, and this is a lengthy survey. So there were some intrinsic difficulties in terms of presenting this to people. So we did see that we lost a lot of survey takers along the way. So we had to educate new people coming in. Not only did we need to educate people at the beginning of the process, and also the respondents, because one thing is answering 5 questions, and another thing is devoting 15 or 20 minutes of your time so that the person will actually focus, because this does require concentration, especially if you have to determine a preference. Do you prefer this or that? So it was hard to reach the number of subjects. Here it says the initial objective was to ask the questions to 1,000 people between the ages of 21 and 75. So those are the problems we ran into as we did this study. And that meant that it took longer than had been foreseen. It's because of the problems I touched upon. It took us longer than what we thought it would. So I repeat, that was the experience that we had. These were things that we were clearly able to deal with, but it did take time and effort. And another thing is that because of all of the recruitment problems, etc., and since the time kept stretching out, we did an analysis with what we had. That was 800 surveys that had been done, and the Euroqual, Federico, etc., did their analysis, and it was felt that the analysis with that number of participants were consistent with the group. So the final number of people surveyed was 800. Now, regarding the different stages in the survey. First of all, personal data, age, gender, educational level, experience with diseases, if there is any disease. Then the form, since we had the 5 dimensions with 5 options, so that the patient could tell us what the health status was perceived by the individual at that point in time. And then we showed them the VAS, and here the patient had to determine his or her perception of health status at that time. And then there were 10 different tasks of trade-off. And here you can see the EQ5D with the 5 dimensions and the 5 potential statuses. If 11111 would be the best possible health status, and quadruple 5 would be the worst possible health status. But there are things that require discernment. For example, looking at the worst potential health status possible, sometimes that is because of extreme pain or extreme disability. And again, this assessment has a lot to do with religious, with social values. So in some of these statuses, these things have to be taken into account. Here you have the VAS. Henry and Federico have talked about this, and here the patient marks a level in terms of the perceived health status at the time. That VAS records the perception of the respondent using a vertical scale where the 2 extremes are best possible health and worst possible health, and then there's time trade-off. Here, participants are asked to imagine a poor health status described in terms of EQ5D, 5L, and for each health status, the participant decides if they would rather live for a period of time of full health, followed by a period of time in poor health status, and then die, or live for a period of time in good health and then die without having to go through a period of illness. As you can see, this is not something that's easy to convey. It is not easy for the respondent to be able to put him or herself into that situation. So you do have to be patient as a survey taker. You have to have enough time to explain this and to make sure that the respondent actually understands the question so that the person can respond in a suitable fashion. Now, as I said, we had 805 subjects between 20 and 83 years of age. 55% of those surveyed were women. 44.7% of the sample said that they had no limitation in terms of any of the domains of EQ5D, 5L, and the distribution in the country was that 15.5% of the surveys were carried out in the hinterland, in the departments of Maldonado and Paysandú, the rest in Montevideo and the metropolitan area. We excluded people that consistently evaluated themselves as being in the saying that they assessed as bad the best health statuses in the survey. That means that these people were not understanding the questions, and so those surveys were eliminated because the person clearly had not understood the purpose. So the procedure was that the survey taker would, first of all, provide some welcoming remarks. Also, the survey taker was accredited by the Public Health Ministry. There was a written information regarding motivation, the usefulness of the research. The person gave informed consent, and then the person was asked to describe his or her health status using the EQ5D5L, and again, they used the VAS. Then came several questions having to do with discrete choice. That is, what do you prefer? Would you prefer to be in this situation and then die? Or would you rather be in this situation and then go through another health status? So different options were put before people. And then they were given an example. Then there were questions about 7 pairs of statuses. And then there was a brief wrap up. Now, regarding the results, this is what we got. This is what we got in terms of the visual analog scale, and this was classified by age group. And basically, the perception that we got, those of us involved in this study, and later on, when this was shared, we think that the sense of the population regarding their health scale was relatively good. It would seem that we Uruguayans have a good perception. I'm sorry, we just lost the sound. We have a good perception of the qualities found for different health statuses in our statistics. Those were figures from Euroqual, and what we wanted to do was confirm what we already envisaged, but we did get data in terms of assessing qualities for different health statuses in different countries, so we could see what the situation, what the result was for Uruguay with the same types of health status. And what we saw, we proved that for different health statuses, for example, for 11111, the 1151, the quality values for different countries are quite different. And it seems again that Uruguay had a better perception of the health status than in other countries. And here you can also see how economic assessment studies can be done with qualities from other countries. And that can have some problems, or it can take us to a certain level of errors in terms of differences, fluctuations in quality for different health statuses.
Another exercise we did at that time, and this is also linked to other countries, well, we wanted to try and see with regard to 3 techniques for the kidney function replacement. We asked for specialists to tell us, or for them to agree on, which was the health state corresponding to the chronic kidney patients, those that were in post-surgical and those doing the peritoneal dialysis. So we had a set, not a set, but a value of EQ5D. And then we applied the reference figures that we had from other countries and for Uruguay. And what we see here is a tremendous difference in the assessment of that health state in different countries compared to what we had from the table that we were able to develop from the health state. So this is aligned with the importance when you follow this path of EQ5D when doing the economic evaluation or following through certain assessments by the population, how important it is to have local data given the differences that we see when we use data from other countries. Conclusions and future challenges. The final sample with good quality interviews was suitable despite being lower than what had been expected at the outset. And in our analysis, the DCE showed results that were not consistent in some levels having to do with severity. In other words, it's difficult for people to assign differences that can then be translated into the values of the 5 dimensions when there are close by levels of severity. So we need to perhaps look into this a little bit more, maybe break down the descriptions, or as Federico said, perhaps have greater scale of options so we can better differentiate the evaluation of different situations. These results were consistent with what has been found in other countries. This, as I said, is a survey that was quite complex to carry out, both for the interviewers and the interviewees. And we did also find that later studies were needed to identify the health states corresponding to the health pathologies or conditions on which a cost utility study wants to be carried out to apply the utility table for the Uruguayan population, given the differences that I've already shown the qualis in our country compared to qualis in other countries. So this is what I wanted to share with you, and obviously I'll be more than happy to answer any questions you may have for me. Thank you very much, Graciela, for telling us a little bit about the experience in Uruguay. Lastly, we will hear from Ecuador by Victor Flores Prosen. He's an economist. He has worked for 6 years in the Health Economics Directorate of the Ministry of Public Health of Ecuador as coordinator of the Health Statistics team, as a coordinator of the Pharmacoeconomies team, and director in charge of health economics. He is currently National Public Procurement Service at COP. Victor is a co-author of the study he is about to present. Thank you very much, and good morning to everyone. Before beginning, I'd like to make sure you can hear me clearly. Yes, we can hear you. Thank you. Before beginning my presentation, I would like to thank you for inviting me to this webinar, and I'd like to also thank RedETSA, PAHO, WHO for allowing us to be part of this group of experiences in countries. So without further ado, let me show the experience of our country when it comes to the studies, or in this case, the use of tools having to do with instruments that allow us to analyze the qualities. At first, in my country, we identified, and we're having some sound problems. There are some interruptions, some interference. So the Ministry of Health decided that it was necessary to have a tool to assess the health state of the Ecuadorian population, and that this then may help the decision makers. Once this prioritization was determined by the Ministry of Public Health, the team within the Health Economics Department started to look through literature and look at international experiences. Victor, I'm sorry for interrupting you, but where your slides are not moving forward. You need to put it in the correct presentation mode so that we can view the slides as you're talking about them.
Ya, perdón, ¿me confirman si me pueden, si ven la presentación?
Is it now correctly in presentation mode? Yes, now it is. Thank you. I do apologize. So I was saying that there are 3 phases in the country. The first was a prioritization and deciding on this by the Ministry of Health. Then the team searched the literature, trying to find cases from nearby areas in the region and international cases. So why a need to use the instrument EQ5D? Our study began in 2015, 2016, and information was developed in 2017. At first, we decided to do the study using the EQ5D 3L. because there are hypothetical health states looking at a combination of the 3 levels of response and the 5 dimensions that the instrument evaluates. It gives 243 hypothetical health states. So there are other instruments that we have been hearing throughout the earlier presentations. And again, we're having sound issues here. So some of the words are missed. So there's the Rosser instrument and other instruments, but we wanted to also look at what international countries had been doing. So we looked at the case of Chile. They use the 5-dimension, 3-level instrument to evaluated 2,000 individuals of greater than 20 years living in the metropolitan region. They looked at 42 random health states compared to the 243. This instrument is also used in Argentina, in the cities of Buenos Aires and Rosario, in small urban areas. And they also use the 243 health states. And lastly, we have Brazil, where the study was applied to a sample of 3,362 individuals aged 18 to 64. In Brazil, they assessed 102 health states out of the 243. So why do we have this figure of 243? Well, obviously, different experiments were done, and there are international experiences showing that the minimum health states to be assessed is 42, because these reflect the model's behavior that gives statistically significant evaluations, and it's a robust model. And that is why it has been decided that 42 health states is the minimum to be applied. So we would look into either using 42, 102, or 243 health states. Now, this became somewhat complicated because to assess 243 health states by so many people would imply a very broad data set for this kind of study. And that is why, based on international suggestions, we decided to use the 42 health states. The main objective was to determine the social preferences for health in the Ecuadorian population using the EQ5D methodology and analyze international experiences in order to have a tool to best develop the public decision-making and policy decision-making for the best health of our population. In the case of Uruguay, you heard about some complications. There is no doubt that the instrument itself is complex, and the methodology also. It requires a certain level of knowledge to understand the problems and to be able to provide the answers to the questionnaire. So managing these problems is fundamental in order to be able to generate information that will later allow us to achieve our goal, which was to evaluate health technologies. So the Eurocall EQ5D3L questionnaire is the one used, and we had 2,314 individuals with 302 surplus individuals should we not be able to collect the necessary data amongst the original group of individuals. We were looking at people aged 18 to 65. They were geographically was broken down nationally of continental Ecuador. In this case, the 23 provinces of Ecuador, with exception of Galapagos, obviously, because that would lead to a higher cost to mobilize the surveyors, the interviewers, for them to travel to Galapagos. So in order to avoid that expense, Galapagos was left out. but the information was obtained from rural and urban areas from different regions in the country. Some of the problems identified include that since the country is culturally multi-ethnic, in the specific cases when translators or interpreters were needed, their services were used, the services of interpreters or guides, in order to be able to reach out to the population and be understood. As I mentioned before, there are 5 levels that are being, 5 conditions that are considered when they have no problem, or moderate, mild problems, severe or acute levels. The additional instruments that were used were ranking, in this case, to have a score for the health state. And again, the interpreter regrets, but the sound that we're receiving is not very good. The VAS was used with a rating and the TTO that has already been mentioned.
Out of the total of the 243 health statuses, we evaluated 42. It maintains the same statistical significance, and that is why we looked at 42 health statuses. Now, we, in selecting the sample, worked directly with the National Statistics and Censuses Institute, and they are the ones in charge of the household surveys done in the country, and they provide national figures. So we worked with them in choosing the sample, and they, based on their expertise, recommended that we use a framework that they use, which is the National Employment and Unemployment Household Survey. And through a probabilistic sample study,
como habíamos mencionado previamente.
we worked with the 23 provinces, as I had said, and in that way we determined our sample. In addition to that, we looked at expansion factors. It is true that it is a very small sample, 2,300, and certain studies were analyzed that will call for expanding this to the total population. But there were international recommendations that we could extrapolate the population. Now, under 3, this has to do with data collection. As I just mentioned, we took into account several inputs to gather information, including the EQ5D, the VAS. Also, we used other instruments that have been mentioned, and we have the distribution of the sample across 3 provinces. And training was offered. And here it's important to say that we had 2 consultancies, one that was international, and that was under Dr. Victor Zarate. I know that he has collaborated with other studies too. I think in Henry's participation that was mentioned. Also, we have a Mr. Zarate. He is an expert under the Qualis, and that person provided us with advisory services for 6 months for gathering the information and for training the team that was working with the Ministry of Health and in charge of the survey, as well as a consultant group that actually gathered the information. So Victor Zarate had 5 people on his team,
En realizar,
and they were in charge of doing training on instrument management, and also they worked with the Ministry of Health to develop several inputs, manuals, so as to implement the survey. Also, we did pilots to validate the instruments, and in the case of there being problems, we would have made adjustments before we officially gathered the information. It's important also to say that the EQ5D questionnaire was translated into Spanish because there were terms that perhaps the population wasn't going to understand. So we adjusted the terms to provide better understanding on the part of the population. Also, we did field control measures. For example, we organized visits, and here the consultant in charge of information gathering was involved. And this took 2 or 3 months, if I'm not mistaken. So there were team coordinators in the field to validate the implementation of the survey, to make certain that the form was being filled out correctly. In the case of TTO, to make sure that we were asking the questions correctly, because under time trade-off, remember, we're asking, do you prefer health status A to B, or would you prefer to live in a certain status? So that is an exchange between the survey taker and the respondent. So in order to avoid any problems in terms of information gathering, we did field control. Now, under 6, actually 5, he corrects himself, the creation of the database. Here we use different filters, different screens. This was done by the consultant for information gathering.
Para disminuir el error al ingresar la información.
We were certain to avoid errors in entering the information. Several intake process measures were taken into account. And if the information was not consistent, we would go back to the form to make certain that the information was being entered correctly. Under 6, we did have quality control for the information. As Graciela said when she talked about her country, there were some problems in terms of the information reported by survey takers, in part perhaps because of the complexity of the instrument, in part perhaps it was a lack of understanding. So here we based what we did on the survey done in the United States that was for Spanish-speaking population. And they talked about 11 criteria of exclusion when you validate the information in the database. And finally, we came up with the database. And with the database, we obtained these results. It is important to say that the structure of the questionnaire involved 9 sections. Now, it is true we could have included other sections. For example, what Federico was saying it was important to analyze the living conditions, the condition of caretakers, that type of question. And we thought of including that in this study, but because of the time that it takes to gather the information and the complexity of the structure, the methodology of information gathering, we tried to reduce the number of questions and use some screens to avoid bias in the information. So here in the results, you can see greater participation of men, 53 to 46%. And then we can see that the younger population has a higher perception of health status, and then that goes down as the population ages. So we can see 31% versus 8.85% for the group between 60 and 65 years of age. Here, another question. Do you have any disability? You can see that 96% of the population said no. And here in this case, greater participation of the mestizo population in terms of civil status, almost 40% were married. Here, schooling, years of schooling between the ages of 11 and 13, we have the highest rate. Now, is there any affiliation? This is, do you have any sort of insurance coverage? You can see that 65% of the population says no. In the last 30 days, were you sick? You can see that almost 46% said yes, they had been sick in the last 30 days. And the last question that we consider to be relevant for inclusion is, have you ever had a serious disease, either personally or a family member or a third party that is close to you? And here we can see that there is no bias in subsequent information gathered under this instrument.
Pero previo a la aplicación
Here,
de la
this is before we applied the time trade-off methodology, so it's a self-assessment on the part of the respondent for mobility, for anxiety, depression, and personal care, pain, everyday activities. Most of these people have no problems. So the health perception on the part of the population is good. And also, when we look at the visual analog scale, this is a vertical that goes from 0 to 100, where 0 is the worst health status.
Momento de realizar el estudio,
The population of Ecuador, when we did the study, on average, says that we have a positive, favorable perception of our health status, 86%. That is the average between men and women. You can see 87% men, 85% women, and we have a tail on the left with a greater concentration of scoring between 60, 70. But we see the highest levels here at 90. That is replicated in men and women, and we see that the assessment is between 80 and 90. Here, we have a comparison between the countries that have carried out or applied this instrument at different points. And this information was gathered in 2017 over a 3-month period. And obviously, the study here in Ecuador was published in 2019. So as we can see here on this first row, 11121, you can see that the UK is at 0.85, Chile 0.807. Ecuador has a positive perception that is better than other countries, 0.95. And we can see that in cases of death. Here you can see worse than death. These are negative coefficients, and obviously that was treated in a certain way to get these results. In the UK, you can see it's higher than in Ecuador and Chile. So we can see that there is, I'm sorry, we lost our sound, and more favorable in Ecuador's population. This is something that we can compare on this graph. What we can see is that the hypothetic health statuses, it is Ecuador in green, and then you can see Chile and the UK in red and blue. It is important here to mention that to reach these results, our model was applied by random aspects with an R of 96%. The estimators were favorable. I'm not showing them on this graph or in this part of my presentation.
Que no abarcan, pero en el caso de que si es que quisieran realizar análisis.
If you want to do analysis of our results, you could definitely have access to our study. Now, here we are comparing the 243 health statuses, comparing the UK, the Latin American population of the United States, Chile, and Ecuador. In purple, we have Ecuador. In red, we have the Spanish-speaking population in the United States. In green, we have the UK population, and in blue, Chile. Now, you can see the perception of health status, and in our country, they are more favorable. As a phase 2, here in the country, the Ministry of Public Health has produced some instruments. In this case, they developed 3 instruments, a manual to prepare quick reports to assess health technology. And here we had searched the literature, and this has to do with different types of health technology. The second manual is a manual to produce budgetary impact analyses. As we know, we look at economic, monetary factors having to do with certain health technologies. And then lastly, and this is an important component in terms of using this instrument, is this manual, the third manual. It is a methodology manual to do health technology assessments. And basically, that is what has been mentioned already, comparing 2 health technologies, for example, to look at quality adjustment life years, look at monetary effects. And as phase 3, exactly where do we want to be as a country? In phase 1, we talked about implementing the instrument, looking at different health statuses. And then second, we have developing the tools to look at budgetary impact and economic evaluation. And what do we want to do? What we want to do is to evaluate or develop reports or economic evaluations of health technologies. This, of course, should be anchored to the priorities set by the Public Health Ministry. And in this case, this would be in the hands of the authorities once priorities are established, once they look at what they want to be studied. And this, of course, is tied to the budget and to the different components required. Now, for the time being, I think that that is what I have to share with you in terms of where we stand and how we have used this instrument, but we would like to develop economic evaluations, assess technologies, apply this to specific target populations, all of this, of course, depending on the priorities set by the Public Health Ministry. So basically, that concludes my presentation on our experience here in Ecuador. Here we have the links to the studies, to our manuals, and so thank you very much. And if you have any doubts, any questions, we are at your service. Thank you, Victor. Thank you for your presentation. Unfortunately, we're not going to be able to have questions from the audience. Most of the questions have been answered by Graciela, by Federico. They have been answering questions through the chat. A couple of questions have not been answered. Federico, Henry, if you would agree, perhaps you could answer a couple of questions. In addition to thanking all of the speakers, because the truth is, this webinar today has been very interesting. But those who are not used to using EQ5D shouldn't be scared. You have to understand that one thing is studying, making an assessment of social values that was seen in Uruguay and Ecuador. Those were the 2 experiences from countries in the region that we share with you today. But this experience, in order to look at those experiences in Uruguay, Ecuador, is great. So once you have the preference table of the population, you can use the questionnaire. That is something that Federico and Henry commented on. So this is a 5-question questionnaire with 5 or 3 options as they answer, and it's easy actually to apply. So I did want to make that comment. I didn't want anyone to go away thinking this is too hard and they do not want to do it in their countries. So it is important to have a validated study for your population.
I was maybe too pessimistic in my presentation. I didn't want to really convey that kind of pessimism. I just wanted people to be aware of the reality. But it's part of the process. On the one hand is estimate the preferences, and on the second, it is to estimate the quality of life of a population with a pathology or whatever. So the two questions in the chat that have not been yet answered. Ophelia Nocetti asks, and it's an interesting question. Differences with developed countries, the different health states, could these be explained by the fact that they have more demanding standards of quality of life than in the Americas? That's one question. Adriana was also asking if there is any idea as to the approximate cost and average time needed to conduct a study, for instance, the one done by Uruguay or Ecuador. I can address the first question. Yes, social preferences indeed, or the quality of life is higher in our countries because we are accustomed to what we have, and therefore it doesn't affect us to perhaps feel a little bit of discomfort or having some kind of issues in different dimensions. So I don't think it depends so much on the standards of the quality, but rather how each society evaluates what they have and what can be lost, because in these social preference studies, what is done is to see how much one is willing to sacrifice. The time trade-off, for instance, is how long is one willing to sacrifice in life in order to have good health. Less time of good health instead of more time with some kind of health issue. So it is expectable to find such differences. With regard to the cost and logistics for these studies, well, that depends on the methodology employed. So, for instance, if one uses the standard methodology of Eurocoil with the TTO and the combined studies with Uruguay and Peru, these studies require about 12 months with a budget of about $100,000 or a little bit more, maybe. The studies had been partially financed by Euroqual and by the ministries of health locally. Now, as to the new methodologies that Henry mentioned, these are still under review, still like the discrete choice. These are easier methodologies requiring less training for the interviewers. And that is perhaps easier also for interviewees. So these studies can be conducted and they require less resources and they might be a little bit more efficient. They're not the standard methodology as yet, but perhaps Henry has more information about this. So let me offer the floor to him.
Thank you. Thank you. So a couple of things. Thanks for that, Federico. That's a pretty comprehensive answer. On the first issue, there are systematic differences in the preferences between countries. And we've had a few papers. I've authored one myself that looks at the impact of national culture on preferences in health. And there are many cultural things that go into how people think about their state of health and a hypothetical state of health. We could have another meeting one day and talk about that. With regard to the evaluation studies, yeah, many of the issues that were discussed by Graciela and by Victor have been solved. Over the last 5 years, the evaluation protocol has been refined and updated, and now we've solved most of those problems. Further, the new DCE with duration that we just piloted here is a huge success. And it will be recognized very soon, formally recognized by Eurocall and accepted as a valuation possibility. And this is great for our countries because we don't have time trade-off in it. We have a very simple set of questions that the respondent has to answer. I'm open. If somebody wants to talk more about this, we could email me and we could discuss that. But it will have the status of a formal valuation method within a few weeks. There'll be a statement on that from Eurocall. Yeah.
Muchas gracias, Henry. Bueno, muchísimas gracias a todos.
So thank you very much, Henry, and I'd like to thank all the speakers. Let me remind you that the recording will be available next week on the RedETSA webpage if you want to download it or share it with anyone. And in closing, let me offer the floor to Vanya. Thank you very much, and let me thank each and every one of you. There were more than 200 people that joined us today. So this is obviously a topic of great interest throughout the region. I'd like to congratulate all the panelists who shared their practical experiences in Latin America and the Caribbean. And that is so important for us, as Alexander said. We discussed this topic at the RedETSA meeting in Jamaica in November, and we see that EQ5D is a tool with many uses, and the characteristics of a population can impact the health state, as we saw, for instance, in Trinidad and Tobago. It also has to do with the educational level. And to have local data is essential for economic evaluation studies. They can result in mistakes in assessing or evaluating the results. So it was very successful for us, and this 40th webinar of our network was truly important. The next one will involve patients. It's going to be a webinar with H Technology and Assessment International. We'll hear from Conitec Brazil, Conitec in Argentina. We'll hear from the Spanish network and the colleagues from HAIT. The webinar will take place on 26 April, 9 a.m. Washington time, 10 a.m. for Brazil and Argentina. So thank you all very much, and I wish you a very good weekend, and we look forward to see you at the next RedETSA webinar. Goodbye, and thank you.
Un gusto. ¿Cuánta gente paciente? ¿Cómo nos extendimos
Nos
mucho más?
aguantaron hasta ahora, Federico, ¿te das cuenta?
Sí. People remain connected despite our late ending here, so that was very good to see.
Muchas gracias.